Hello, I'm Richard Weaver, GP Director and Head of School for General Practice.
Hi, I'm Mike Masding. I'm the Head of Wessex Foundation School and I'm a consultant physician at Poole Hospital.
Morning, Mike.
Hi, Richard.
Good to be speaking to you today.
Yes, you too. I just wondered whether it was worth discussing the current pressures and issues in both primary and secondary care and how we can still train doctors in that setting. What do you think of the issues with primary care at the moment?
The primary care is coming under increasing pressure. There's a lot of factors combining to make GPs look at their career choice to stay in general practice. We're seeing much earlier retirement. We've seen a change in part-time working increasing all the time. Less people wanting to be full-time GPs, and people are being put off by the noise in the system at the present moment, I think.
But there are still lots of good opportunities to have a fairly varied career in primary care.
I think general practice has been a fantastic opportunity for people if they but appreciate it, because not only are you able to do clinical general practice, but there's a whole lot of other branches that you can get involved in. For instance, I've been involved with a career that's spanned medical politics, teaching, emergency medicine, family planning clinics and so forth. So I've had the word we use in general practice is portfolio career. And that has given me lots of new interests as I've progressed, and I have changed my role and jobs over the last 30 years.
And likewise, I've had lots of fantastic clinical assistants working in my diabetes clinic over the years, indeed one who did it for 25 years, who developed a real specialisation, even a subspecialty interest within diabetes, and who was a fantastic person to work with. So there are lots of opportunities in primary care, I think, to have, rather than just the conventional sitting in a GP surgery and seeing a list of patients. There are lots of opportunities.
I think that's what gives it the variety. I mean, the day-to-day job in itself is full of fantastic variety, and each patient is a new experience. You may have seen them 30 times over the last 20 years, but each time they come in, it's a new opportunity, and it's a new problem to help solve, and that's what's great about it.
So what skills do you think a 21st century GP needs?
The same old skills as before: listening skills, communication skills, expressing yourself to the GP. You need the medical knowledge, obviously, and you need to be up to date. But it's that one-to-one relationship that you build with the patient that's so important.
And if we move on to education, that one-to-one relationship between the doctor in training and the trainer is still very much there in GP, isn't it?
Very much so, yes. You see people on a regular basis. They will select to come to see you because they know you and they want to see you again, and you have the background story. So it's like starting up a conversation after a tea break or something. You're picking it up again.
Okay. And how within the system do you think that we can ensure that high quality training for our junior doctors can still happen in primary care?
I think it's very important that everybody gets the opportunity to have a time in general practice to see how the patients' lives influence their illnesses and how their illnesses influence their lives. I think it's good to be able to go out and see them in the community, to have a conversation with patients. Sometimes it's very minor stuff that you'd never think would be important, and other times there's heart-stopping moments when you think this is not going to be a good story to go along, and you're exploring that journey and supporting the patient through that.
As you know, I am a great supporter of GP in Foundation programme, and I think it's a really fantastic placement for our Foundation doctors to do. What do you think a Foundation doctor can get out of a GP placement, a 4-month placement, particularly if they're looking in for a hospital career?
Yeah. I think it's one of the really great places that you can hone your consultation and communication skills. I don't think anywhere else you will get the same level of feedback and supervision around that particular aspect of medicine. A lot of learning for medicine is about gathering facts and knowledge, but this is the one place you can practice applying that, talking to patients, explaining things to patients, and learning to communicate with patients. It's so important, and GPs are really good at teaching that and giving you the time to do that.
And as a trainee, you have a one-to-one relationship with your trainer. Is that something that you think is helpful?
Very much so. It's the one place that the true apprentice model still exists, where you're working alongside and with a senior clinician who's experienced and fully trained to give you feedback. Because we pride ourselves on our communication training and skills, and it gives you the opportunity to practice, to talk about things as well.
if you're a foundation doctor going out to do a GP placement, what other opportunities might there be outside the traditional consultation?
Well, there's working with other team members, and you can get to go and visit with the nurses, see the wider community placements. You get to go and see people in their homes and look at their environment and the problems that they're facing. There's social services, there's all the different specialised clinics. We nowadays run lots of chronic disease management clinics with senior nurses who are supporting you and will give you a lot of insight into the day-to-day management of these chronic conditions.
Okay. And other non-clinical opportunities?
Yes, there's medical politics, so you can go to the local medical committee meetings. You attend educational days where you get together with groups of other foundation trainees and have supported teaching from a foundation lead educator. You've come up through a hospital career,
yeah,
but now you do some GP practice, or not practice, you work in a GP setting.
Yeah.
How's that been for you?
It's been absolutely brilliant. One of the things that I've come to realise in my 15 years as a consultant is that you never stop changing and learning. And my clinical work has changed hugely in those years, and I think will continue to do so. The NHS is always evolving, it's always changing, and one of the ways in which it's changing is a lot more work is going out into the community. So for the last 2 or 3 years I've been doing clinics in a community hospital and now in a GP surgery, and it's great fun. We should never forget that working as a doctor can be great fun. The patients really appreciate you seeing them in a local setting rather than having to go to the local hospital. And I think as specialists we often forget that it's a real pain for people to get to hospital. And parking's really difficult, and the hospitals are often not in great settings for public transport. So me seeing them locally is really, and I've got feedback on this, that the patients really appreciate that. It allows me to practice medicine in a slightly different way without some of the constraints we have in the hospital setting around IT, around other team members who may or may not be present. So I've really enjoyed it, and I think one has to say that for all of us in all hospital specialties, it probably is the way that things are going that we'll be expected to do more and more work in the community.
So when you go to the practice that you work in, you've got your own consulting room, and
yes.
What about IT support?
Yeah, I have my own consulting room. I use the same IT system as the GPs use, so System 1 in that particular group of cluster of practices. So I see patients not just from that practice but from other practices come to that GP surgery, but because the IT is very supportive, it means it's very helpful. It means I don't have to work in a traditional way of writing a GP a letter and then taking 2 weeks to get there and then taking another 2 weeks for anything to happen. I can go and knock on the door of a GP next door and say, can you change this prescription, or send them a message on the IT system. So we have found that things happen, and the patients have commented on this, that it's much more efficient. Things happen much more quickly.
So you've got direct access to the patient record and entry onto
and direct access to the whole patient record. Whereas if I'm working in a diabetes clinic in my office, I only have access to what's on the hospital systems. Whereas in the GP setting, I have access to everything they've had done in the healthcare, including all that stuff that's on the secondary care systems as well. So I found a way to work it that's I have to say, I think is much more efficient than what I'm doing in hospital. I guess it might be slightly different if you're doing a specialty where you have procedures. I don't have a procedure to do, but if that's just a matter of moving equipment around, I can't believe that's too hard. The support from the staff in the practices and in the community hospitals has been exemplary. Such nice people, really helpful, and I think there's a genuine feeling that they're glad to see you, because again, I think it's good for patients that we're seeing them locally in places that they're much more familiar with.
And is there an opportunity for the clinicians to come in, the GPs or the nurses to come in and speak to you and consult you?
Yes, absolutely. On any number of occasions, there's been a knock on the door, usually at the beginning or the end, and we've talked, about different clinical issues. One of the other things I've done in setting up that service is an email service with the GPs, and we do count things, and we've probably avoided 40 odd patients in a couple of years having to come and see me just purely through managing via email. And whilst that may not sound much, these are only monthly clinics, so that's 4 months worth of clinics I've managed to avoid. Yeah. So I think in the modern setting, and our younger doctors will be much more comfortable with this, there are so many different ways of communicating that you can provide a secondary care service in a much wider way than just the traditional clinic model.
And do you know the size of the patient list you're covering for these practices?
It's 6 practices. It's the Purbeck area I run. It's 6 practices. I couldn't tell you how many, but it's over 100,000 people.
Quite a lot.
So big population of people, and it's also the links building up with the GPs and with the practice nurses means that we're also teaching them and upskilling them in looking after patients with diabetes. Mm-hmm. So my hope is in 2 or 3 years' time there'll be a whole load of patients who I've traditionally seen who I won't need to see anymore because they will be looked after by the GPs and the practice nurses, although they'll always have the fallback of being able to contact me and the diabetes nurse I work with for advice. And certainly the feedback we've had from the GPs and the practice nurses is that they feel well supported and really feel that our service has been very, very helpful. But I think it's very important to see that the service is not me and the diabetes nurse. The service is me, the diabetes nurse, the GPs, the practice nurses, etc., etc. And it's it's all working together. One of the things I have always felt is that individual patients don't really understand the difference between primary and secondary care. They just see their own health. And it's us who make a divide between primary and secondary care. And us working together with the GPs, with the practice nurses and all the people in the community has been a real joy and has made you realise that actually you can provide really good joined up care if we break down those barriers. And the patients really appreciate that.
Excellent. When the service was first set up, who set about doing that? Was it yourself?
Well, it's one of those things that come about, wasn't it? It was a conversation I had with the GP just in passing. Somebody I knew, mm-hmm. And then another of his colleagues I met at a football match, and these are how things. Get started, I guess, almost by accident. But then it's very important to just follow them through. There are some managerial barriers we came across, and one has to get across those. And in the end, to be brutally honest, Richard, you just end up just doing it. And I think we could still be sitting having meetings about what we're going to do if myself and the GPs not just said, let's just do this.
So that's do it first and ask forgiveness later type
absolutely.
Approach.
And of course what you can do in a sort of quality improvement type model is that you get things started and then you find, well, this doesn't work, so you do something differently. So for instance, at the first clinic I realised I didn't have a blood pressure machine. Actually, it didn't matter that much. We still talked to the patients and all those sort of things. And then in the second clinic, I took a blood pressure machine along. It's not a big deal, but you find those things as you go along. But if we'd never started, we would never have found that. Even some of the IT stuff at the start, we didn't use System 1, we just used the hospital systems, and I dictated a letter as I would have done traditionally. And then gradually over the time, we've now come to the point where I don't dictate a letter at all. I type into System 1, and that's there on the GP notes. I copy it, copy and paste it into the hospital systems, and it works really, really well. So we've moved from when I started doing the community clinics, very traditionally dictating a letter and it being sent, typed by my secretary and it being sent out to the practice.
Weeks later.
At the earliest it would leave the hospital 10 days later, and then it's all got to happen after that. To the point now where I think the record between me putting a task on System 1 and the GP changing the patient's prescription was about 90 seconds. Wow. That's got to be better for the patient.
Yes.
And that's what we must always remember. It's always about the patients. I like going out there. It's very pleasant. I go to Swanage and it's sunny and I can buy an ice cream and that's lovely. But actually it's better for the patients in Swanage, and that's the most important thing. And likewise, the what I see as much better communication with the GP has to be better with the patients. And in fact, a lot of the patients have commented on that.
Excellent. And were there any costs to setting up the service?
Again, I would say we had lots of conversations about that, and then over about 6 months, and then we realised we weren't getting anywhere, so we just did it. I'd like to say that the trust were hugely supportive of it, they have realised that it's the way things are going, and that we can't just sit as sort of secondary care experts, so-called, in our little ivory towers and pretend that there's not a world out there. And my trust, and the senior management have been hugely supportive of me going out and doing it, because they see it as the future, and they see it as the engagement and working with primary care is the only way forward.
Well, you're being the pioneer, so are there any other clinics plans from the hospital?
I don't know. I certainly in diabetes there is. We're now looking, not myself, some of my colleagues are looking to provide a similar service in other areas around where we are. One of the great things about doing it was working from a blank sheet. And that's actually a fantastic thing for any doctor to do. It's very difficult to change things in a large organisation, but when you go out there and they just say run a clinic and do it how you like, that is a really amazing opportunity that actually doesn't happen very often. So it's a great opportunity. My colleagues see it as a great opportunity to go and run a service. They probably won't run it the same as me in other areas, and I think that's absolutely fine. But it's a great opportunity to design something, and we may even be able to compare outcomes in a few years, those sorts of things. But if you don't just get out there and do it, things will never happen.
Yeah. One of the things that hospital allows you to have is instant investigation, X-rays, ultrasound, getting tests and things done. How does that?
Well, again, it may be my specialty that is less important, and of course that may be much more important in other specialties, particularly around things like cancer and heart disease. But nonetheless, there may be opportunities to provide some of those investigations in other settings. Or prioritising them coming into hospital. I'm a great believer in trying things out, and if they don't work, we'll just don't do them again. But if you don't try them out in the first place, you'll never know. So I'm sure there are lots of things actually we can't do outside the hospital, just for the equipment that's needed or economies of scale. But I'm sure there is an awful lot of stuff we could do outside. And I would encourage my secondary care colleagues rather to go and do it. It's fun, and I would encourage my primary care colleagues to ask the question: can you come out and do this here? But be encouraging, work with us as secondary care colleagues, because we're all working for the good of the patient. And the primary secondary care divide, I believe, is a false one.
I've got one last question. I know in Dorset they're doing an exchange program where you go and shadow another GP, and a GP comes into the consultant. Have you been part of that?
I am going to. I haven't yet. It was just that my the chap I was shadowing. I'm going to twinning, I think is the correct term. The chap I'm twinning with, it was just sorting out our diaries. So in another month or time, I'm going to see what he does in the morning surgery, and then we felt the best thing for him to come and do, rather than sitting in a very subspecialist, because at the hospital now my diabetes clinics are very subspecialist, stuff like diabetes and pregnancy, diabetes in adolescence, and whilst that might be interesting for a GP, it is very specialist stuff. But actually what he's going to come and do is come on one of my ward rounds, our general medical ward rounds, to see what we do on the wards and what we might be able to do a bit differently, and where some of the things that we traditionally have done in hospital perhaps could be done in the community. So he's coming on one of my ward rounds, I think in a couple of weeks' time.
Certainly the GPs that I've shadowed, I've spoken to, have been very positive, and it's opened their eyes, because I think we sit in two different camps, and we always think the other camp's better off than us, and we actually learn that we're not.
Yes, and I know the consultants have felt that very same. It's often the case with foundation doctors when they go out into primary care that they say, I didn't realise how few, proportionally, patients they refer. When you're sitting on the end of a phone and people are referring all morning, and I've done this fairly recently in acute medicine, it does feel like everybody's referring everybody. When you go out there into primary care, you realise that it's a tiny, tiny, tiny proportion of the patients who are being seen are being referred. And I know some of my colleagues have commented on that they didn't realise just how much is done out there, even before referral. So how much investigation and management. So I think it's a fantastic scheme. I would encourage people elsewhere to do it. If we can't spare half a day in a year to see what our colleagues are doing, then things really are in a desperate state.
Yeah.
And I do think that the future of healthcare in the UK has to be breaking down the primary-secondary care divide.
Yeah. And interestingly, in discussion just the other day, the specialists were saying it would be good for them to go cross-specialty, to spend half a day with another specialty.
Yeah, it's just knowing people, knowing what people do, because we all have our preconceptions about what other people do, and some of those are even ingrained from time at medical school. Which for some of us, Richard, it was quite a long time ago.
Thank you very much.
But me included as well. Yeah. Those attitudes get very ingrained, and the only way you can ever change those attitudes is by really talking to people and seeing what they really do. And as you said, everyone feels everyone else is always better off than them. If the National Health Service is going to survive, it's actually about us working together. It won't survive through competition. No. It won't survive through people trying to do down what others do. It'll actually be survived by working for the good of the patient and working together.
And I think that's the same in primary care, where practices have to begin to work together.
Yeah. And we've certainly seen that locally where practices are doing that.
Thank you very much.
Good.